I'm Audrey Kok, a physician based at the Netcare Union and Clinton Hospitals in Alberton. I have a large diabetic practice and a special interest in type 2 diabetes. This series of case studies translate the starting insulin program to which I contributed into everyday clinical practice. I will present a simulated but real-world case that we and our patients typically encounter in managing type 2 diabetes. Today's patient is Joe Claessens, 60 years of age, whom I first met a few months ago. Joe had been diagnosed with diabetes 10 years ago and was now very frustrated with his situation, as he realized that he was not at target levels for his home glucose levels. Joe had never really been educated about his condition adequately and felt that turning 60 was a wake-up call for him. He now wanted to make a concerted effort to improve his diabetes management, and he still had 5 years of work left before his planned retirement. Initially, Joe had been treated with a basal insulin combined with metformin, but had to increase the dosage of the basal insulin significantly to 66 units daily. He split this at 36 units at breakfast and 30 units at supper time. While initially the basal insulin had seemed to work, he was gaining weight. Joe was unhappy with his glucose readings, which frequently exceeded 10 millimoles per liter. His own doctor had now retired, and so Joe consulted me. When I saw him, his blood pressure was elevated at 164/95 millimeters of mercury. He is 1.72 meters tall and he weighs 106 kilograms with a waist circumference of 108 centimeters, which makes a BMI of 35, and he had a resting pulse rate of 92 beats per minute. He had edema of his legs, evidenced by swelling to mid-calf. Pulses were present and equal, but his feet were sweating and wet to touch. He had a history of shortness of breath at night and found the exercise program hard to manage, although he persisted. There were no audible crepitations at the lung bases. At his first visit, it was clear that the basal insulin, despite the high dosages and twice-a-day use, was not effectively controlling his diabetes, even when combined with metformin and a DPP-4 inhibitor. So we first concentrated on monitoring the postprandial glucose levels, and I explained how these would assist us in managing his diabetes better. By understanding the impact of postprandial glucose levels on overall control and how these values influence the HbA1c, Joe better understood why the basal insulin alone, despite metformin and a DPP-4 inhibitor, was not achieving the control he sought. His HbA1c level at this time was at 9.8%, but the postprandial glucose level were in excess of 12 to 14 millimoles per liter. His ideal target levels should be between 7.8 to 10, and at most with fasting between 4 to 6 millimoles per liter. His blood results revealed an eGFR of 62 with a positive microalbuminuria. The lipogram showed an elevated LDL cholesterol of 3.6 millimoles per liter, triglycerides of 2.7, and an HDL cholesterol of 0.9 millimoles per liter. At his age, he felt that improved glucose control would help him to make him feel better, to avoid any diabetic complications in the long run, and he was well aware that the risk of high glucose levels are significant. He already had an exercise program. He was very motivated to address the carbohydrate in his meal choices as well. There were several concerns. He had all the features suggestive of an elevated cardiovascular risk at the age of 60 and being male. He has an elevated pulse rate, symptoms and possible signs of early cardiac failure, and his reduced estimated GFR indicates stage 2 renal failure with uncontrolled hypertension. In addition, the sweating of the feet indicates a sensory peripheral neuropathy, which must be investigated, as it will influence the choice of treatment. His obesity influences the type of insulin and dosages to be used, and also the approach to treatment as per the ADA-EASD guideline update of 2020, where they do consider weight and obesity as important factors to be considered when choosing diabetic therapy for these patients. We also need to consider the renal function and elevated blood pressure, improve his lipid profile, address the heart failure symptoms and signs, and exclude possible sleep apnea as a reason for his symptoms. Additionally, at his age and with his level of activity, his life expectancy and the desired quality of life, our HbA1c target, which we discussed with him, will definitely be 7%, and ideally even as low as 6.5% if we can achieve that safely. In such a case, our therapeutic options could be, number 1, to add on an SGLT2 inhibitor or a GLP-1 receptor agonist, as these agents target both the cardiac protection as well as reducing weight, and it will protect the renal dysfunction and may actually reverse it. Secondly, we could adjust the insulin regimen. Here we could either adjust the dosage of the basal insulin, complemented by a bolus dosing schedule at meal times with a short-acting insulin, or we could change to a premix insulin with specific postprandial glucose reduction in mind. The third option is to adjust the type of basal insulin to a longer-acting agent and to combine this with a GLP-1 receptor agonist, which has been shown to reduce hypoglycemia, again reduce weight, and result in excellent HbA1c improvement with renal protection. But of course, this comes at a much higher economic cost. Now, please consider these options and complete the CPD questionnaire before we discuss this case further.